Now we're moving on from anticoagulants and platelet inhibitors. Remember how I said some slides ago that anticoagulants do not break up clots? They are not clot busters. They stop existing clots from getting bigger and they prevent new clots from forming. But there is a drug that's considered a clot buster, and these are known as thrombolytics. In the book, they refer to them as fibrinolytics, same thing. And on page 275 in the book, we start talking about fibrinolytic drugs. And in table 14.2, we have some fibrinolytic drugs listed. So you can see here in this cartoon, you can look at it more closely if you're listening, without having to actually hold the phone up. But this guy's working at the Heart and Vascular Plumbing department. It says if you've got a clogged artery, just run these IV and watch them increase perfusion, decrease viscosity, and aggregation of RBCs. So it gives some other good info. So make sure you look at this cartoon very closely. For instance, it says watch for allergic reactions, spontaneous bleeding, oozing from any fresh wounds. So the fibrinolytics or thrombolytics are very, very frequently used in the event of medical emergencies. And what are those medical emergencies? I'm glad you asked. You can see from this slide that they are given in the event of acute MIs, acute pulmonary emboli, acute ischemic stroke, and acute arterial occlusion. So these have to be given within a set amount of time after each medical emergency, and it depends on which medical emergency when you're talking about the time. So what do the fibrinolytics do? They convert plasminogen back to plasmin, so they kind of go backwards, which breaks down those fibrin clots that we talked about, breaks down fibrinogen and reverses those other plasma proteins. So if you go to that very first picture where we showed the clotting cascade, and if you had it in a VCR, you could just hit rewind and kind of go backwards. That's sort of what you're doing. You're breaking down all that, those clot factors that formed, and that helps break down clots and get them out of the circulation where they are interfering. So we've got a couple of prototype drugs. We've got a drug called Alteplase, also known as TPA, and that's tissue plasminogen activator. That is working to break down that plasminogen and get it going again rather than clotting. This drug is also referred to as Activase. These are high alert drugs, and they're given IV, and they have to be given under strict supervision. This is not something you would just give with home health. It's going to be given in a clinical setting. Now, if you have an acute MI, TPA can be given, and it's best if it's given within 12 hours of the time when symptoms began. So you're going to ask this person, when did you first notice this chest pain and this pressure and this nausea and sweating? Ideally, the person has sought medical help as soon as these MI symptoms start, because, remember, people are told about these and hopefully they get medical help. So hopefully it's not going to be a whole 12 hours, because an awful lot of cardiac muscle damage can be done in 12 hours. So hopefully it's been within a fairly short time. But it's going to work the best and break up that clot that has developed somewhere in one of those cardiac arteries if given in that 12-hour time period. Acute pulmonary emboli, where they've been able to go in and use a CT or an MRI and see where this clot is in the lungs. And it doesn't give a time for that, but once again, this is an emergent situation. The person probably is going to seek help as soon as they start having that chest pain and difficulty breathing, and they can get that right in there. Now, an ischemic stroke, remember, is one where a clot is blocking oxygenated blood from getting to the brain, as opposed to the hemorrhagic stroke where there's been a break in the integrity of the blood vessel. Hemorrhagic stroke, of course, clot busters aren't going to work. In fact, they'd make things worse. But with an ischemic stroke, where you've got a clot blocking off circulation to the brain, we are told to give the TPA within 3 hours of the onset of symptoms. So suppose it's 3 o'clock and the person's just kind of sitting there at their desk after their work day, and all of a sudden their face starts drooping. Their words that they are forming sound fine to him in his brain, but they are not coming out the way he's trying to express them. Maybe one side of the body goes flaccid. Hopefully someone's going to call 911, going to say, all of a sudden about 3 o'clock, this person started showing these symptoms of a CVA, and so we got him straight to the hospital. Generally speaking, that 3-hour period of time is the time when the benefit is higher than the risk. Remember, we talked about that benefit-risk ratio, where the benefits of any kind of drug outweigh the risks of that drug. Of course, we know that clot busters are pretty risky. But if you can get that into that person within about 3 hours, the benefits outweigh the risks. Afterwards, the risks start to outweigh the benefits, because within 3 hours, you're going to see some brain damage. You're going to see oxygenated blood having done damage that's probably going to be permanent. And then arterial occlusion. Maybe the person has a big clot leading to a major organ, or in the artery of a leg that is really threatening to keep oxygenated blood from getting where it needs to go. That's a serious effect, and that fibrinolytic needs to get in there very quickly. So it's going to be given under strict supervision, cardiac monitoring, watching that person, usually in a hospital setting.